2, 1, start. Good evening, everyone, and welcome to the 5th Conversations That Matter series in collaboration with the HSE. This evening's conversation will finish at approximately 10 minutes past 7, and there is a question box on your screen, and we would like to invite you to ask some questions to the panel if there's any areas you want more information on. My name is Caroline O'Regan. I work with the Institute of Leadership in the Royal College of Surgeons in Ireland. I'm very pleased to have the opportunity to continue these discussions about the impact on families in this COVID-19 crisis. This is another complex and very sensitive area and is particularly challenging in this pandemic. I would like to welcome our panel of experts. Welcome back Dr. Miriam Colleran, Consultant in Palliative Medicine, St. Bridget's Hospice and Naas General Hospital. I'd like to welcome Ms. Orla Keegan, Head of Education and Bereavement Services with the Irish Hospice Foundation. And welcome back Dr. John Fitzsimons, Consultant Paediatrician, Temple Street and Clinical Director for Quality Improvement. And welcome also Dr. Kevin McCarthy, Consultant Paediatric Anaesthesia and Pain Medicine, CHI, Our Lady's Children's Hospital, Crumlin, and Temple Street Children's University Hospital, here with us this evening to continue our conversations. Tonight specifically, we will be talking about impact on families in a much more specific sense. For those of you who could join us last Thursday, we discussed COVID-19 in relation to loss and bereavement. And we looked at how decades of our traditional practices and rituals have changed overnight. We talked about how clinicians have proactively developed materials to support families. We've looked at all of the learnings that are happening from the different teams around our health system who are demonstrating collective leadership at every level across the organisations and leading their services. Things like taking times out to debrief each other, adapting novel ways of communicating with PPE. We also spoke about the challenges of isolation and social distancing, and ironically how social media in isolation is no longer isolation, and it brings a whole different perspective. We delved into the thing of loss of social and cultural practices, specifically visiting our loved ones with the traditional bunch of grapes is no longer permitted. And this is not just COVID-19 patients. So this evening we want to continue this conversation about the social impact and how families are coping in this pandemic. So Miriam, Orla, Kevin and John, it's lovely to see you all and you're very welcome. So I'm going to pass you over to Miriam now, and Miriam is going to continue the conversation on discussions about families and how they are affected and in relation to the social impact on children. Thank you, Miriam.
Thanks, Caroline. Last week we explored, as you described, the impact on children, ICU care and compassionate care and grief, and also the sudden change to our funeral practices that have arisen from COVID-19. As clinicians, we are trying to balance and negotiate infection control and public health needs and the psychological and emotional needs of ill and dying patients and their loved ones. Furthermore, we are trying to be diagnostically and therapeutically skilled, but also recognizing our role as being a therapeutic presence for patients. As Heaton Shah described, epidemics are social as well as biological phenomena. Today, we will continue the discussion on COVID-19, how it's impacting on patients and their families, whether or not the patient has coronavirus. As this pandemic is progressing, information and evidence is changing and expanding rapidly, despite this being a very new disease. So we must keep adapting on an ongoing basis. Sue Morris from Dana-Farber said, "The coronavirus pandemic has upended our lives and routines in recent weeks, generating fear, uncertainty and anxiety. Coping with this disruption, adjusting to staying at home, working remotely, and distancing ourselves from others, among other changes, has been difficult for many. It can be especially challenging if someone you love has died during the pandemic, regardless of their cause of death, as the ways in which we typically grieve and honour our loved ones are unavailable or altered. Furthermore, she described that for those who are bereaved and grieving at present, that this time is an incredibly difficult and isolating period. Orla, I am delighted to have you here today. The Irish Hospice Foundation has developed a wonderful Care and Inform series and is very active in disseminating supports. The references that we discuss will be uploaded into the repository that RCSI are kindly hosting. We're going to chat today about the impact of COVID-19 on families, but of course, as you have said to me before, families always start with the patient. I know that bereavement and supporting children is a special interest of yours. So firstly, may we start with discussing grief and loss at this time.
Okay, thank you very much, Miriam, for that introduction to what really is an important topic. None of us are individuals. We live and we are created and we are connected through our families into our communities. And I guess what I was thinking of, the way I was sort of thinking, maybe answering your question, is to look at the notion of what families may have experienced or lost through the pandemic in general, and maybe how that then is magnified if they've lost a family member or are expecting to lose a family member. And I sort of was thinking and talking a lot really with people over the past while, that the way we, I suppose, organise our worlds from when we're young children through to when we grow up is by having core assumptions about how the world is and how consistent and predictable and safe it is. So that's a really strongly held assumption. We don't have to rethink that every day. We get up and we go out into the world expecting it to be as it was yesterday, more or less. We also construct a very strong assumption about the meaning of the world. To think of it as, ultimately, a just place, that there's a natural order to things. We might think, we might have God as part of our meaning. So the assumption is God has helped create this meaningful world for me. We might have assumptions around science and cure and what can be done. And they're all very internalized and we don't really have to question them. In times of loss and trauma, like a pandemic, all of those assumptions get shook up because the world is no longer that safe, predictable place. A lot of our meanings are no longer as relevant as they once were. There isn't, particularly if you're facing the death of somebody, there isn't a justice in a young person dying. That's going the natural order, going against what I expected and the way I think the world works. So we could be looking into that and saying that our assumptions are potentially in a position where they're shattered and rebuild a world. And I think we also have assumptions about maybe other people being there for us. We have very strongly held assumptions about what supports us in bereavement. And we talked through about that last week, about the script of the funeral and people will be there for me. That's shattered. And the final set of assumptions that as individuals and within families we hold are assumptions about ourselves and our own self-esteem and what makes us worthy and worthwhile. So we have identities as a good person. I'm a good person. Don't really happen to good people like me. I might have a very strong assumption about I'm a good wife and I'm a good daughter. And along there's lots of the things that you do with being a good daughter. Like I provide for my mother. I make sure she's looked after. I will be with her at times of threat. So all of those are up for grabs in pandemic, and when somebody has died, they're shattered even further. So that metaphor that our whole ground has been undermined, and the situation that bereaved people find themselves in to the power of 10 just now.
And I suppose what you're saying there very much reminds me reminds me, or I think I've told you before that both of my parents sadly died of rare cancers. Our mom died at home, and a few years later, our dad died in ICU. And as family members, my brother and sister and I, we were fortunate. We were very lucky. We were there with both of our parents when they died, and it's been an enormous comfort to us, you know, to know that they were dying peacefully and comfortably and actually be there. So for families now coping in this pandemic when they have a loved one dying, how can we help them?
Okay. Well, I suppose the first thing is, and maybe elaborate on this, that what happens in an illness and through death and at the time of death is all a part of bereavement care as well, and can help in their coping. If the death has already happened, so thinking of the people that maybe are currently bereaved, what we really need to do is get in and scaffold them in a very basic way. So basic care, making sure they can look after themselves, put one foot on front of the other, connect them in to others, be persistent in our phone calls, in our texts, in our support. Provide them with information. You mentioned the notion that there's so much information out there. People need to feel, oh, this is not only me who feels like this. I've gone through this. So there's lots of sort of shoring up and scaffolding and helping we can do with people who are currently. And I think what we need to emphasize there as well is people are survivors, copers, and strong. And in the main, that's for them.
People have resilience.
They do, and a natural resilience. And we're not just spinning that, we know that from research. So with the horror that's going on, it's balanced by a sort of an instinct to survive. In terms of what you were saying about, you know, your own parents and how important it was for you to be there around the time that they were dying, I think you'll understand from that there is always something that can be done, from the smallest gestures, communications, comforts, that are probably very live in your mind, even at this point. So I think, you know, a lot of that doesn't have to be pre-planned. It's people just being present and giving of themselves in the moment. But there are, I suppose, a certain amount of things that can be planned in, and I know particularly now when people are maybe limited in terms of certainly the amount of time that they can spend visiting, and potentially have difficulties visiting at the time of death. There'd be things that we could plan in terms of being very aware of what's important to that patient, what, you know, music, readings, voice recordings, you know, anything that can be bringing the family to that person's bed on a more elongated time, not just at the very short intermittent phone calls. So I guess our role is to be proactive in offering some of those things to people, because they're in this situation for the first time, and they won't have had time to think about what might help. So being able to be proactive and to offer things is very important, I think. There's another, I guess, and again, as health professionals, you'll all know this and will have heard about the notion of anticipatory grief and work that you do in advance. And again, a lot of that does come down to the communication and the gestures. But the other concept, I think, that we put a lot of store in is the concept of preparedness, and anything that can be done to help prepare a relative is a good thing to do.
Preparedness.
And there's a number of, I suppose, ways that you could look at that word. But thinking of families as being in a foreign country when they're in a hospital. And you really need to, I suppose, help to spell out exactly what they're going to see or hear, what's going on. Again, assume nothing and try and set up for them some expectations. if they're not going to be there, and if safe staff won't be there, and if the family won't be there at the time of death, or there's a fear that they won't, it should really be explained in advance. But what usually is going on in that ward, there is always somebody there close by with your relative. And answer as many unasked questions as you can.
Okay, that's really important. So, Orla, can we come back to this again at the end when we're having our chat all together? Actually, that would be wonderful, because I know John and Kevin are going to chat with us now.
Sure.
Thank you. Thank you so
very much.
Yes, I'm going to pass you over to John now, who's going to talk to Kevin. Thank you, John. Thank you, Kevin.
Thanks, Miriam, and thank you, Orla. Yeah, it's a pleasure to welcome Kevin here this evening. Kevin, you're an experienced clinician, obviously working with children at CHI, but I suppose it was your experience as a child rather than working with children that we were keen to discuss this evening, because you recently experienced what it was like or you're still experiencing what it's like to have a relative in hospital. Would you like to just tell us a little bit about your experience and how it feels to be a patient or a relative at this time?
Sure. Thanks, John. I think I definitely prefer being a doctor and being a clinician to being a relative. There's a lot less certainty and a lot, much less of a sense of control or being able to control events as a relative. And particularly at this time, my dad had a stroke on Good Friday, and we haven't been able to visit him since then because of visitor restrictions around COVID. He's doing okay. I FaceTimed him the other day. He was in good spirits, looked a lot more dapper than I was expecting. And the care he's receiving is excellent. His team are fab. The nurses are fab. It's just very difficult for us as a family not being able to visit him and not to see him, face to face. Even though we understand logically the reasons behind that and the very good reasons, it's still just I don't know that connectedness or that closeness, that physical closeness that you'd like to have just isn't possible at the moment. One thing that I perhaps shouldn't be surprised by in Ireland is the response of, I suppose, the wider community. I put a call out on Twitter the day after it happened, looking for a phone that he could use, and the response was just phenomenal. Several hundred people replied or passed on the message. I think I had offers of about 15 or 20 phones, from Limerick and Cork, and people that were willing to try and travel or try and get it to him some way. Friends of friends, former colleagues, even total strangers who I've never met before but who work in CUH have said, popped in to see him just so that there's somebody to just, I guess, to try and break up his day. So that kindness and those offers of support have been very heartwarming and very reassuring. And I suppose, they're in Cork, I'm in Dublin, but even that distance, feels like I might as well be on the other side of the world at the moment.
And it's that, I suppose, the effect of that distance making it just difficult to do the things that you'd normally do, I suppose. And when you did get to FaceTime, was that something that helped? I mean, in terms of being able to see your dad? And
yeah, no, definitely. It was. I think sometimes our imaginations can run away with us a little bit, and this is even as someone who's been working in the healthcare system for 20 odd years at this stage. And I think I had this mental image of him as some kind of, King Lear kind of character waving his walking stick at the nurses. But when I actually saw him, he was quite cheerful and happy, and I think they'd given him a haircut as well. And he was actually his consultant. I think they just finished rounds, who gave me his phone to FaceTime with him. And he was Dad was pestering his team, telling them that he has free travel and he can come in and out every day. They don't need to keep him overnight. So just that little bit of banter that it's for me, it was a sea change in how I've been as a relative and as a son, in terms of how I've been coping it and how much I've been, I guess, obsessing and mentally micromanaging different things. That I feel a lot more reassured now, and nothing in relation to his medical care, but just the physical act of seeing him, face to face,
And I think that's one of the things, I suppose, that maybe builds, what the experience of being a patient is those small moments or those little things that people do, and how the importance of even the tiniest things, the little kindnesses.
Yes, and that's been the thing. He can reel off the name of everyone that he's spoken to, the other people on the ward. There is a rhythm and a routine to a ward, I think, for being a patient as well. There's sort of an ecology to it, for want of a better word. And I suppose the at the moment, and certainly as a clinician, because of the with COVID and all the emphasis on safety and all these new protocols that people have to remember, and this total change in how we work, that we can remember, I guess, some of the softer elements of care that are so important.
And how are the rest of your family finding it, Kevin? Obviously, you have a medical background. It's slightly different maybe from some of the others. And how are they all managing?
They're okay. I think I'm the only medic in my family. Like my parents are farmers. And I think I've been the translator, or the person at the nominated person to speak to the medical team. They're okay. They're finding it difficult as well, and I think for them they're all in Cork, and they're not far away. So it's physically not far, but they still can't see him. So it's no easier for them, even though they're closer. One thing that CUH have been doing, which my brothers are getting onto, and I think have jumped on, is being able to email things in, and they'll print it off as a letter and then hand that over to him. I think a few hospitals are doing that now. So I think my nieces and nephews are going to get press ganged into. Well, as I told my brother, get his daughter to write a letter, and he can do a drawing, and send both of those in. So. Hopefully he'll have a steady flow of letters in and out, or in, I suppose.
Yeah, well, that's super, and I think that's kind of cross-referencing lots of the things Orla was talking about there, the scaffolding and the things that we can do to help people. Has there been anything, Kevin, that's surprised you, I suppose, through the whole experience, or?
I suppose being a clinician is immediately focusing on being a doctor before being a son, and in some ways it's easier to think purely in terms of medical prognosis and problem solving, and thinking of the logistics of how things are going to work out afterwards, for discharge planning and things like that, and I suppose focusing on the factual things. And I found myself, or I've caught myself saying, it's like, okay, you've got 15 minutes to be upset about this or to be stressed about this, and then you've got to get a phone, you've got to figure out this, you've got to figure out something else. So I suppose sometimes I've caught myself a little bit being medical about it, rather than allowing myself feel the feelings associated with just having a dad who's just had a life-changing event, who we can't see at the moment. So
that's great, thank you, and thank you for sharing that with us. And I might hand back kind of into the discussion there, if Orla wanted to pick up on anything there from Kevin's story, or Miriam.
Well, I was just going to say thank you indeed for sharing, particularly when you're in the middle of things. It makes it all so real. And I think it's beholden on us all to remember that we are families, we are not individuals. As I said at the beginning, we often have to say this an awful lot in our own work, like, we are the bereaved. So it's not about, you know, always working out to help others. We have to reconnect with the, I suppose, the core experience that is ourselves. So, I think you work in the children's hospital, and we often hear that about children, how their imagination is worse than the reality. So just when you said there about actually seeing him and the relief in that and what it meant, they're really powerful messages. Thank you, Kevin.
And Kevin, do you think this influences your, I suppose, experience back into your work in Crumlin and Temple Street? And
yeah, definitely. It's something that with the, I said, the emphasis on COVID, almost to the exclusion of everything else, all these new protocols that we have to learn. It's something we've been working on anyway, was trying to not lose the things that we would normally do for children coming into hospital. So, you know, the things that we demedicalize it. So for as an anaesthetist, for them coming to theatre, you know, we move away any you know, scary machines, or, you know, nobody's gowned up, you know, before they come in. Whereas now everybody's gowned up. We look like the bad guys from ET. And, you know, that, you know, remembering that that must be all basically we're doing the exact opposite of what we would normally do for, you know, for children, but also for parents. I think with a lot of emphasis on the child and the focus on the child, but sometimes, you know, forgetting what it's like for parents. You know, it's an incredibly stressful event, having a child in hospital, having a child going for surgery, and as you alluded to, it's a foreign country. You know, it is. We forget because it's we do this every day, and we do. You know, we give so many anesthetics every day, and so many, you know, kids in and out every day of the week, every week of the year. But it is a foreign country, and it's a place that most people, you know, would never want to find themselves in. Yeah. And perhaps, you know, and this is before COVID, never really thought about it that much, because they don't want to think about the, you know, the unpleasant thing or what it's actually going to be like. So trying to trying to help people navigate that journey. You know, and not losing that, you know, maintaining the emphasis on safety, and obviously all the new precautions with COVID, but not losing the, you know, that quality as well. Yeah.
And you're really describing compassionate care. You're really describing compassionate care, Kevin.
Yeah, and that's the I suppose, you know, that's the thing. You know, we say it takes a village. You know, it takes a village to treat a child, and it's you know, trying to make sure that there isn't any additional morbidity or any longer term consequences, you know, any more than they need to be.
Sure. Do you want to check questions?
Yeah. Okay. I'm going to just go over. Thank you so much for that, Orla, and thank you so much, Kevin. That was very it's very moving, actually. So I'm just going to check with Tina now to see, the audience have been invited to submit questions throughout the last 30 minutes or so. So I'll just check with Tina and see if we have any questions for the panel.
Thank you, Caroline. Yes, we have two comments in at the moment, and one of them is for Kevin. And by Kevin, they're just wishing your dad a speedy recovery.
Yeah.
But I suppose the question is it fair to say that as an adult child or a child, sharing and seeing in the reality of having a sick relative makes the whole thing a little bit better? So just in terms of your daily work, I suppose that personal experience, does it change the way that you practice on your day job?
I would hope that it hasn't, that we practice in a compassionate manner, and that we do practice compassionate care as much as we can. Anyway, I suppose the it has made it more front and center, I guess, because you can only, in terms of your attention span for any of us, you can only hold so many things in your attention at one time. And I suppose that's the thing with this new way of working for all of us and all these new precautions that we have to take. It takes up so much space, and it can easily push the rest to the side. I suppose it has re-emphasized for me how important it is to be a navigator for children and for parents, throughout their journeys into hospital. I've found this much more difficult. I suppose the difficulty I've had, or the change, has been being a relative rather than being a clinician. I suppose, I don't think it's dramatically changed how I practice, or because this is something we had been cognizant of anyway. But it has. This was a lot more difficult than I expected it to be as a relative and as a son. Even though you have all this experience, that kind of goes out the window a bit, because it's still your parent, or it's your relative who's going through that. So I don't know whether it's been a good thing or a bad thing being a clinician, going through that experience, because I don't know any other. I've been doing this for about 20 years, so or graduated around 20 years ago. So, but it's I would rather not have gone through it.
Of course.
Yeah. But there's a really nice comment in from Liam. There's a really nice comment in from Liam, who says that as clinicians, we know the territory and the terrain so well. And sometimes we forget that this is the first time people are interacting with the service. And it's a very frightening situation for them at the best of times. So in a sense, that the role of a clinician is to be the guide for children and for families, and not to forget that. And there's another question in as well from Dr. Dela, which says, in preparing clinicians, not just for the exhausting work that they're doing physically and psychologically, but also preparing physicians and clinicians for this, what has happened to you as being a relative. Is there any one piece of advice that you might give to others in your situation?
Yeah, I think I think this applies both as a clinician and as a relative. As a clinician in what is a very strange time and very stressful time, and I don't think it's like 6 degrees of separation, or I think most people know somebody who's been affected by this in some way, and so both as a clinician and as a relative. Personally, I've found it that I've ended up trying to rationalize or suppress my emotions or my feelings, that not giving them adequate time. That let's say with the a job well done at the end of the day is you get all of your patients through, and everybody has done their jobs well and effectively. But there's so much, everything is more heightened, and everything's kind of ratcheted up now in terms of tension in relation to the PPE and how we're practicing and how we're working. And so I found that at work, and also I suppose in being a relative, that I found myself rationalizing what I'm feeling, or suppressing what I'm feeling, rather than just feeling the emotion and not judging it, or not giving myself time and space to feel the emotion, whatever it is. There's no wrong way to feel in this or any situation, and then I guess process it properly, rather than trying to over intellectualize it or rationalize it. And I think that applies generally as a clinician, but also in the being on the other side of the fence as well.
Okay. There's one or two more, so
we have time.
Yeah, there's one or two more. So there's one in from Daniel saying, Kevin and Orla, thank you both for your contribution. We're trying to find ways to keep connected with loved ones. And Daniel's question then, is there anything else from a family perspective that we could do?
For me?
Well, maybe Orla, do you want to take that one?
I was going to just say that in a way that's a really lovely question, because the first thing we'd often say is to ask and listen as to what a family may want. So it's that dance between offering the things you have, but also asking. I guess even just us talking about families, we know how different every family is from each other, and how different each of the individuals are within a family. And so I guess what we probably need to think is that one person will want one way of being supported and another may require another one. So that how we tailor our responses to who we're with is, I think, a huge challenge. And I don't think as clinicians you can underestimate how much pressure you must be under trying to deal with multiple people. And there's nothing as complex as family under stress. So I think asking is always a good maxim.
Okay, there's one final question. I might just ask that. So there's just one final question in then about, and I think we touched on this a little bit last week as well, but really to the panel, what do you see as being the long-term impact of visitor restrictions and limited funerals on people and their families, on their grief?
Orla, would you like to, because you have been going to discuss preparedness more, would you like to discuss that? Yes.
Well, I think the piece in terms about not being with the family member is huge. I mean, that's again what everybody would wish for, in terms of their own death, to have somebody around, and in terms of the people they love to be there. So it's you can't underplay the impact of it. I think one of the things when we were talking about preparedness is, well, in what way can people be facilitated to, as much as possible, not have unfinished business? And again, that to some extent to help some of the important things to be said, and even if they have to be mediated. I love you. You know, families have traditions, a lifetime of traditions, in terms of how they communicate or don't communicate, and those words don't come easily to some families. So in a way, helping and gently shaking up ingrained ways of communication can help prepare somebody to have a better grief later on. The funeral piece is very difficult in the moment. I think my own, and it doesn't sit naturally with any of us, but people are creating new ways and trying new things, and they're not, I suppose they're not crumbling under it either. And what I would, I suppose, you sometimes hear people are saying they're putting their grief on hold because they haven't had a funeral, and I don't think that is the case. I think grief is grief, and it's work, and it goes on, and it's a process. The funeral is a part, and it's a ritualized part of introducing us to the reality of death, and of, I suppose, taking the person into our heart so that they exist more inside in us rather than outside anymore, and giving us a community to witness what we're going through and be comforted with. They're all important things, but they are also functions that can be met over time and in smaller ways. And yeah, there can be a big funeral in the future, but it doesn't mean that grief isn't happening in the moment. I think we do, in answer to the question, we will have to look at maybe some some longer term plans. I think people are doing fine in the moment. There will be a proportion of people who really will struggle, and it could be 6 months, 12 months. And what support is there, we know for a fact is patchy as of now, particularly for bereaved people. It's one of the poor relations within mental health. So yeah, planning is going to be required.
Okay. And there's just one final comment. There's just one final comment in from Anja saying, thank you, Orla and Kevin. Very relevant and honest account of the heart wrench that many families are experiencing right now. And Kevin, wishing your dad a speedy recovery.
Yeah, something we all reiterate here, Kevin.
Absolutely, absolutely. All the best to you and yours, Kevin, and to your dad.
Thank you. Thanks. I'll pass that on and try and film his reaction if I can. So
yeah, lovely.
Okay, if we have no more questions, I think we can wrap up. Unless the panel have anything that they would like to add finally before we say goodnight.
No.
No. Okay, so I suppose some of the key takeaways, and indeed, Kevin, speedy recovery wishes to your dad and comfort to you and all of your loved ones in his recovery process. So a few of the key takeaways we have, I suppose the current one that keeps happening at every conversation we have in this area is that patients whose lives are sadly cut short by COVID, we want them to be peaceful, natural and appropriate. And we spoke about the rituals and, you know, the importance of advanced care planning and communicating in whatever way we can to loved ones. And then the unnatural sense of the ritualization of funerals and how that's been completely turned upside down. But that bereavement is a journey and that stays with us. We also talked about the whole thing of shattered assumptions in this new world we find ourselves in, and how that scaffolding support is really helpful for families. And you quite eloquently validated that, Kevin, with your story of your experience with your dad. And I suppose finishing on what you said, that, you know, you're a human person, you're a very proficient medical practitioner, consultant in your area, but you're a son of a dad. So it's okay to feel your feelings and not to try and suppress your emotions and not to judge them and just to go with them. And the temptation of jumping in as the, you know, the medic, the rationalized expert in the area of medicine, to try and leave that to one side and just be a son for this period. And, you know, to try and just move a little bit away for the solution focus, which made me think about when you talked about compassionate care. So, you know, that was very evident that you're providing compassionate care in your own service as a doctor, but also you demonstrating compassionate leadership. And as Michael West would say, you have to be compassionate to yourself first. So I think you talked through that very well. So thank you so much, Kevin, and thank you so much, Orla. I hope that the audience will join us next week, next Thursday, on the 30th of April. At 6:30, we'll have a panel of experts to discuss COVID and the impact on quality. And there are additional supports available through a series of video links and podcasts, thanks to Professor Michael West, who's a senior visiting fellow from the King's Fund and Professor of Organisational Psychology at Lancaster University. And for our audience who have any further suggestions for future conversations that matter, if they could please email RCSI Leadership at rcsi.com. So with that, I'm going to thank you all again, to all of our panel, including Miriam, including John, and again, Kevin and Orla, thank you so much, and again to our listeners. So good night, everybody. Take care.
Thank you.
Good night.
Thank you.
Bye.
Good night. Good night.
You're very good. Bye-bye.